Joe, and thanks for coming out tonight. It's late in the day, so thanks for doing it. We're going to talk to you about ACL injuries, not the actual injury and the surgery and that sort of thing, but prevention of the injuries. And it's a pretty controversial thing. I was just telling Billy that when I was asked to do this, I was a little negative about the prevention strategies because most of the papers that have come out recently, the last few years, have not been entirely supportive of the prevention programs. And last week, our journal, Bone and Joint Surgery, came out with an article that actually advocates for prevention strategies. So we'll talk about that at the end of this. So what do we like to try and do? I'll talk about what the issue is, what things may lead to this issue, and the issue is ACL tears. Some of the factors that we think may or may not lead to this. What do we know? Can this be prevented? And then we'll just have a discussion and answer any questions that you may have. So just to give you a little background on what is the meaning of all this. We do approximately 175,000 ACL reconstructions a year in this country. That's a lot. It's about 1 in every 3,000 people. The cost is around $1 billion a year, and that's for the operative management. That's for the surgical treatment. It doesn't include the non-operative management. It doesn't include the loss of scholarships for athletes, that sort of thing. So it's a huge cost. As many of you know here, women have a higher incidence of this injury than men, and that's the epidemic that we talk about in sports medicine. We're not sure exactly why. We'll touch on a few of those things. The scary thing is that 75% of these injuries are non-contact. It doesn't take anybody running into anybody else. It's just that person in the activity that they're doing. They're associated with other injuries, such as meniscal injuries. And the other kind of scary thing is that even though there's a higher incidence of women, more reconstructions are done on males than females. I think that's really changing, and that's literature that's, we lag behind those sort of things. So, high-risk sports, the sports that you hear about this all the time, in this area, soccer, lacrosse are probably the two highest things, followed by women's basketball. Skiing, it's a completely different mechanism in skiing than the pivoting and cutting sports, like soccer, lacrosse, basketball. Again, depending on the level of performance, you see a higher incidence in different levels. Some of the theories that we talked about things that we know and we don't know, theories around why this happens, ligamentous laxity, so some people are more flexible than others, and there are really good things about being more flexible. There are a few bad things, and this is one of the bad things. We see probably more injuries with less flexible people than flexible people in the overuse phenomena, but ACLs is the ligamentous laxity. One of the theories is that the notch in the knee, where the cruciate ligaments are, is more narrow in people that sustain this injury. It's not been proven. It probably is a factor, but it's not the only factor. There's been people talking about footwear, turf surfaces, that sort of thing. Again, there's some correlations, but there's no evidence there. So, women and ACL injuries, as I said, this is the epidemic that we face. As I said earlier, there's a 2 to 8-fold increase in incidence in women than men. You see numbers all over the literature, and part of that is based on what sport that they're studying when you're looking at those patients. Other theories, the immediate theory that people go to in the difference between men and women is the hormonal differences. There's probably some association again, but there's been no proven evidence of that it's a factor. There are studies that show, yes, there may be a factor. There are equal number of studies that show that there is not a factor. And then the other thing would be the anatomy. Men are built differently than women, and that probably does have a factor. One of the things that we'll talk about and the subject around the ACL prevention theories are the way that women land compared to the way that men land. And that's one of the important things that we try and change with these ACL prevention programs. In women, it's more common a deceleration move rather than a quick cutting move. It takes lower ground reactive forces to tear. They land with a bit of a higher knee abduction moment. Those are the physics behind things. And so I'll show you a picture in a minute from a paper that shows in women's soccer players, women tend to land more erect and stiff. Men tend to land a little bit more flexed in the hip, flexed in the knee. And we think that that's one of the factors. Women tend to land a little bit more on their heel, and men tend to land a little bit more on the ball of the foot, which drives that flexion in the knee and the hip. So those are the things that we think of are factors. And women are usually more flexible than men. I don't mean up here, I mean, we know that they're no more flexible than us in the way we think. So this was a study that demonstrated how women land differently than men, and the other issues that we haven't touched on are things about imbalance in the musculature. The hamstring tendons and the hamstring musculature are supportive of the ACL. The quadriceps are potentially disruptive of the ACL, and so it's thought that women are more quadricep dominant than men, and that may be a factor. Again, we talked about the hip flexion angles. We talked about the shape of women versus men. A wider pelvis tends to set the femur out a little bit farther so that the angle of the femur is a little bit more acute, and that stresses the ACL. Again, just the way people land is important. So I just thought I'd show you a little bit about what an ACL is, the anatomy of an ACL. Again, this is controversial a little bit. We think of the ACL as composed of two bundles inside the knee, and that's important because previously we really were reconstructing only one bundle, and we had good results, but we still saw some instability in knees, and I think what we've done is changed the approach, so we have a combination approach to reconstruction. And the bands do different things, as you can see on the slide. So in flexion, one band has a little more tension and one band is more relaxed, and then extension, the opposite. The ACL actually has nerve fibers in it, and part of the work that people do in a place like this is to restore the function of those nerves, and that's what we call proprioception, or commonly thought of balance is a way to think about it. And so the ACL is the primary restraint, but the thing that you want to remember is the ligaments are the primary restraints, but the muscles around the knee are secondary restraints and are important. So this is what an ACL looks like inside somebody's knee. This is a non-injured ACL. This is the notch of the knee that we were talking about. So one of the theories is that this is sharper in people that are injured. This is the posterior cruciate ligament back here, and the ACL is coming from the shin bone here up to the femur there. So this is what we call the anterior medial bundle. This is the posterior lateral bundle. So you can see this is here, and the other one would go like that, and that's the difference between the two. So what we've done, we used to primarily reconstruct this bundle, and now we put our reconstructions kind of in between the two bundles to catch both of them. Some people are doing two bundles, but that's the minority. This is just an image, an MRI image, showing an injured knee. This is an ACL ligament tear off the femur, and that's the most common place. This is the PCL. And this view, you can see that the ligament here has got a lot of white around it, and that's indicative of a tear. That's what it looks like when you go into a knee. You saw the picture here. That's a normal-looking ACL. That's a torn ACL. And you can see it's torn off the femur up here, and it just kind of balls up in the front of the knee. And that's one of the things that makes it hard for some people to get their knee straight all the way after this kind of injury. Just a cadaver dissection of those two bundles that I showed you arthroscopically. So what's the mechanism of this injury? And I present this material because you have to know the mechanism to try and prevent the injury. So the mechanism is a pivot shift, and we do that test in the clinic after somebody's had a knee injury to assess the ACL, and it's the way the femur and the tibia interact with the ligament. So it's an axial load, so there's a force coming down in those pictures that you saw, and then there's a valgus shape. So a valgus, one way to think about it is knock-kneed is valgus, and you see more women are knock-kneed than men, and men are more bow-legged, and that's a varus. So when people land flat-footed, erect, they land like this, and their leg goes like that. And that's the at-risk position for an ACL tear. And you think, it's just landing, you know, you hop off the ground and you come down, and it doesn't always take a huge amount of energy to cause this. But when you're standing on one leg, landing like that, you know, I'm putting there probably 3 to 4 times my body weight through my extremity. So it's quite a bit of force. Some of the associated injuries, meniscal tears, articular cartilage injuries, and then collateral ligament injuries. This is an arthroscopic picture of the femur is right here, tibia is right here, and this is the meniscus. And why I show you this is meniscal tears are important. The menisci, like the muscles, are secondary stabilizers of the knee. So you lose a ligament, you lose a meniscus, there's a lot more increased instability with that. So we do everything we can to try and preserve the meniscus. The problem is it doesn't heal very well. The other issue is articular cartilage injury. The minute this injury happens, the two bones come together, there's a high force impact on the articular cartilage. Articular cartilage does not respond well to that type of impact. It responds very well to us loading it like this in a controlled manner. It doesn't like to get hit hard like happens with an ACL tear. And that's just a picture of somebody who had an ACL tear. And you could see a minute ago on that picture how smooth the cartilage is there above that silver probe. And then that's what injured cartilage can look like inside the knee. And that was from an ACL tear. So what do we do about prevention? I think it helps to understand the severity of the problem that we face, and that's the epidemic that's out there. The anatomy helps you understand what we're talking about. The mechanism of injury helps us to try and reverse the injury, and then the prevention program addresses that. So what we talk about are neuromuscular programs, and those can be variable, and I'll show you names of several of them. And they all do a few different things. The core of them are exercises around balance or proprioception, dynamic stabilization, and I'll show you some pictures of what we're talking about, plyometric exercises, and that's to provide strength, agility drills, how do people land and strengthen at the same time, and then sport-specific drills for different sports that are doing this. So different ones out there. There's one called the Knee Ligament Prevention Program, CLIP. Santa Monica program is probably the most famous ACL prevention program if you do a Google search. And then Cincinnati had one of the early programs too. And there are others out there. A lot of places are developing their own. We have a variation of these on our own. So there's a lot of them out there. One of the difficulties for us, and Billy and I were talking about it, is, you know, how do you get these put in place? And for you people sitting out there, you know, we need advocates for these to be put in place in schools. That's where they need to be done. There's a lot of resistance for that. One, cost, you know, with the budget cuts that are happening. Two, the limited time that people have for practice in sports. Coaches really don't want to take up that time doing these sort of things. You know, and it's just getting people on board and understanding that if you don't do these things and you have a lot of injuries on your team, you know, that's really devastating for them. So, you know, we need advocates in the community to say these really should be done. So again, I showed you valgus position versus normal or varus position. So on your right, that's position at risk, and that's what we see most of the time. Women land like that, and ligamentously lax guys. The position on the left is how we want people to land, and we do a lot of work with things like this that aren't, when they're not being used for computer stands. You know, they are good ways for you to teach people how to jump off of something and land, and I'm sure that's what happens here in the recovery phase, where we're getting our athletes back to their sport. So that's a picture of one of the things that you need to pay attention to. And then there's just a bunch of different exercises that work on balance. So this is a proprioceptive balance exercise where this person stands up on one leg, bends over, picks up the ball, comes back up, comes back down. Most of these programs don't require that much time. Most of the studies would say they need to be done 2 to 3 times a week, and they take anywhere from 20 to 30 minutes to do. So it is a bit of an investment of time, but I think most of us feel like it's well worth it. And other exercises, and again, one of the things that we stress with this, and I know the therapists here stress, is the position that this young woman is in. So she's doing, and this is one of the tests that we use for recovering athletes after reconstruction to kind of assess where they are with their strength and balance. And you can see in her case, her left leg is up, and she's doing a single leg squat on the right. And what you'll see when you're assessing patients, a lot of times, patients at risk, when they do this sort of thing, their knee will go in, so they'll do that in that at-risk position. And what we try and teach people is knee over the toes. So you can see that this athlete is doing that, and that's an important thing, an important part of this. So the initial programs, when we take them to schools, they're supervised. Then we engage the teams to supervise themselves and to carry on the program. It helps if there's a trainer available. That it's really not impossible, especially in our state, a rural state like this. A lot of the schools don't have athletic trainers in the schools, which help with this sort of thing. Other things like walking, lunges, proper technique, those are all important things. And these are all things that we do in the rehab after an injury, and it makes sense that you should do it before an injury happens. So just proper technique for this. And then a lot of exercise, dynamic exercises, and these are names around these like cone jumps, a bunch of different things that you can do, and it's basically hopping from over a cone, or a ball on the ground, anything you can use. And so it's 2-footed, you go to a single foot back and forth, and all this time you're making sure that technique is right. That the words that we use are land softly, not hard. Making sure that the hips are bent, the knee is bent, and people are landing on their toe. It's a lot easier to land softly on your toe than on your heel. So those are some of the cues that we use when we talk about this. And then forward and back motions. And then there's a bunch of different variations that you can do. But those are some of the basic things. Things that I didn't put pictures in are common sense things we learned about with the back issues, and that's warming up. That's an important thing for these athletes, especially in fall soccer season here in New Hampshire, when you can get out on a field and it's pretty cold, not warmed up appropriately. You see problems with this. So warm up is an important thing in addition to some of the strengthening programs here. So those are just a little bit of a sense of what these programs entail. So does it work? And as I said before last week, I was just going to talk about the fact that one of the later studies in 2010, that there really wasn't a proven effect of these prevention programs. And it has gone back and forth from one paper to another. And in this paper in 2010 out of JBJS, they were using the knee ligament injury prevention program, the CLIP program. And the thing about the CLIP program versus something like the Santa Monica program or the Cincinnati program is that it focuses purely around the knee and not the whole athlete. So one of the things that the other programs work on are core strength, and we heard about that with the back, how important that is. Well, it's important for the whole body really, because the core strength really helps set up the lower extremity. There are some papers that are out now that are questioning, can we get people too strong in the core? Does that lead to problems? I don't think that's really the issue. Last week in JBJS, another paper came out that showed that these programs were effective. So, it's like anything in medicine. There are going to be articles that are in favor of it and articles against it. And I think, as a clinician and a provider out on the field and in the office, I think these are helpful programs. I think things that need to be added to these, like the Santa Monica, is general fitness. I think a lot of the injured athletes go out and they're just not ready participate in the program because they don't have a good general fitness. I think that there are some athletes that are worn out and they play too many sports, and so they never get a chance to recover from one sport to another. I know that's a sin to say that around here, but I think that's what we see. You know, you just can't recover from something. So I think those are important factors in this too. And I think, you know, advocacy from the community is really an important thing to try and get it in the school. And I know places like this are helping with this sort of thing. Through my office, we are having athletic trainers go out to schools to start to try and engage the schools and teach this sort of program. There's a lot of resistance, and kids are busy. You know, they're busy with sports, they're busy with social life, they're busy with homework, and it's hard to get them to engage in this sort of thing. But I think if we're going to have our kids participating in high-level sports, we really need to do the due diligence with this. So, in my opinion, I think these programs are helpful, and that we should be doing them. But, as in this picture, you know, it's not as clear as the string, which is the muddy side, which is the blue side. So, there's a lot of work to do. So that's basically what prevention programs are, the epidemic that we face, and I'm happy to answer your questions. I don't know if I said posterior lateral. If I did, I should have said posterior cruciate ligament. That was in that picture. Okay. Yeah, the posterior cruciate ligament is the one behind. And so maybe you're thinking, you know, we don't hear a lot about posterior cruciate injuries. It's a much bigger ligament. It's a massive ligament compared to the ACL. And the positions of at risk are not as common. So that's why we don't see it as much. There are times that you see an isolated PCL. A lot of times those are big linemen in football. That's who you'll see it in. I've seen it in ultimate frisbee players. You see everything in ultimate frisbee. People think that's a non-contact sport.
No.
We see a lot of Indian football. So yeah, the PCL is one of the states of the ACL, but not as frequent. Could be all sorts of things. Yeah, it just depends on the situation. Bikes are a weird thing because it is good for you, but you have to be fit to the bike. So there are times that if your seat is too low, you put increased contact pressure on your patellofemoral joint. That can cause a problem. If your seat is too high, you can have some hyperextension problems and you get pain in the back. So it could be a lot of things. And if you do have meniscal problems, it can become something. But I agree, biking is really, as I've gotten older, that's the thing that I do. Yeah, it's a little easier, except on your back, where did then you go? Biking is really hard on your back. Again, good biking. Great. Thanks for your time.